Good afternoon and welcome to today's CME activity. There is no commercial support. The speakers and planners have disclosed no relevant financial relationships with any commercial interests. You will receive a SurveyMonkey link after today's activity. If you're viewing online, I will list the link into the chat section, and if you're viewing after the fact, you can find the evaluation link listed in the description section of the video. It is my pleasure to introduce our two speakers today. First, we'll have Dr. Armstrong. He is a graduate of Kansas City Medical School and went to residency in psychiatry at Oklahoma University in Tulsa. He has a degree in bioethics and joined Northeast Georgia Health System in 2020. He currently serves as the inpatient medical director at Laurelwood and is most recently working to build out emergency psychiatry services within the Northeast Georgia Health System. We're also going to have Rashay Blake, who is a graduate of University of Georgia with her undergrad and graduate degree in social work. She is a licensed clinical social worker serving as a behavioral health intake specialist here at Northeast Georgia Health System. Join me in welcoming Dr. Armstrong and Rashay.
All right, thank you, everyone. And this is a topic that's near and dear to me. We're going to talk about safe holding spaces, and we're going to use it to apply to LGBTQIA plus patients, but we're also going to talk, I think a lot of these things we'll talk about, especially in the latter half of the lecture, are generalizable to all populations and patient populations. And something that we'll do not only in mental health and psychiatry, but I think you can apply to medicine as a general rule, even something like our medical records where we document appropriately and creating a safe holding space. So, and as a general rule, safe holding space applies from the minute someone walks through the door, or probably even before that when they're making an appointment, to the end of the visit and throughout their care. So I don't have any disclosures. And we'll talk a little bit about the agenda. So we're going to talk first about some systems. So, you know, as people walk through the door, how do we create a safe space? How do we create in that environment that's welcoming to LGBTQ plus patients? So we'll give some general rules about that, or some general guidelines about how to manage that. As always, I think for understanding populations, having some general idea of the historical treatment of various populations, and specifically LGBTQ plus populations, is important to provide good care and to understand where people might be coming from in regards to their care. And by understanding yourself, I think you can create safe spaces. And we'll define what a safe space and a safe holding space is. And we'll use some therapy models. I'm particular to psychodynamic therapy for any clinicians or mental health folks in the room. But for others, I think a lot of it makes sense in the context of how we might conceptualize a patient visit. And then we'll use that and go into some therapeutic modalities to help define what it means and to be thoughtful about the process of creating a safe space and that one-on-one appointment time, which I think is really important and a pivotal moment in a patient's treatment. And then we'll have a case. Rashay will come up a little later and help me with a case, and I'll talk a little bit about my own personal experience in the medical system and relate to you some of my struggles with that, and then where we can also have positive outcomes. So the baseline for this is there's a lot of studies about bias and about why LGBTQ plus individuals feel sometimes unsafe, often unsafe in our medical system. So in 2015, there was an NIH study, so pretty recent. There's actually, I was looking at the research recently, there's been another study showing similar numbers, 80% in 2015. I remember correctly, about somewhere in the 70% of first-year medical students had some sort of bias against lesbian and gay men. Now, this is probably one of those bias studies where you look at a lot of pictures and you kind of do these automatic assessments. But they did find that there's some level of bias, and that's okay. We all live with bias, and a lot of what we do is how we manage our bias and how do we be better clinicians, even though we might have some bias. And then more than half of sexual minority adults and 70% 26% of gender minority patients report sexual discrimination from healthcare professionals. So that's a pretty high number. And I don't think from talking with my colleagues or medical school folks or therapists that we want to do this, but this is something that people do experience. So we have to be knowledgeable if we want to prevent people from feeling this way in our healthcare setting. And then I think to the end of all this, 1 in 6 LGBTQ patients say they avoided medical care for fear of being discriminated against, and according to an NPR study. So people are actually not seeking out treatment that they might need. And that's one of the holdups, and probably the end game is we want people to engage in the treatment we have to offer and help people feel good and better about their lives. And then just cardiovascular results were worse, and mental health care is not as robust for this population. So types of discrimination that have been described in some of the research studies were demeaning behaviors by healthcare professionals. People have been turned away. I think we've seen this from our 1990s movies like Philadelphia, where people weren't allowed to see their loved ones or be a part of their care. That's part of the history. I don't think we do that as much anymore, but there can still be that bias and care that's certainly there. There's one of the things I think we'll talk about is refusal to use a chosen name or gender, and then asking irrelevant questions to a patient's presenting problem. So that's an issue that's been described. And kind of going down some other rabbit hole and not focusing on the problem at hand. And then one of those other things that I think personally is a problem is you have to come out over and over again at these healthcare appointments, and you don't really know what the outcome of that is going to be, and whether you're going to feel any sort of discrimination in that process. So that can be a stressful experience from the very beginning. So how do we make it a safe space from that very beginning? So these are just some of the data that we can look at. So healthcare provider didn't believe you were telling the truth. 16% of LGBT plus patients report this, double non-LGBT patients. Healthcare provider assumes something about you without asking, 21% versus 11%. And feelings that healthcare provider dismissed your concerns, 29% versus 16%. So these are pretty, almost double shares of population that report these concerns with the healthcare system and during their appointment times. So it's something that is a concern. Those numbers are pretty high, and something that I think we'd like to avoid as best we can, and make sure that our healthcare systems are welcoming environments. So this is just kind of some healthcare disparities. It's kind of hard to see some of this, so sorry about that. But so there's a lot of consequences, just as a general rule, when we're talking about healthcare outcomes and suicidality. So we can see some of the percentages here. And well-being generally drops when we're talking about LGBT healthcare. And I also wanted to talk a little bit about our history here. Like I said, I think it's important to know the history and kind of how recent some of these things have happened. So when we're talking about DSM criteria, I think just from our perspective as psychiatrists, we look at here, the American Psychiatric Association only in 1973 agreed that or homosexuality was not a mental health disorder. So we've made some advancements from that, but you can also see don't ask, don't tell. Some of the things that happened in the 90s was enacted only recently, was gay marriage allowed, and then September 2011, the don't ask, don't tell policies were rescinded. So it's, and I look at the June 26th findings, and it was a 5-4 decision in the Supreme Court to allow same-sex marriage. There's been a history of discrimination, and certainly not feeling part of society. So those are just kind of some of the historical context and that you can look at. But there are some good news here. There are some things that we can do. Therapeutics, visit-centered solutions. So that's great. We have good news bear here. And then, so this is some just strategies systemic-wide. So I'm going to start looking at our systemic strategies to help create more inclusive healthcare environments. The things we can do from the front door and from the website. So how can we create a safe environment from the outset? And how can we help the people that we work around make sure that we're a healthcare giving sort of environment? So the first is actively engaged leadership. So I think, our system probably clearly has some actively engaged leadership so far as creating policies that are going to be helpful and create safe spaces for this patient population and for the people who work here as well. So that's the organizational policy. So these two kind of lead into one another. So non-discrimination policies, restroom policies, family and support person policies that are inclusive and allow for LGBT patients to feel engaged. And this is one that I think gets a lot of headway, and we talk about a lot. So, and I think we do some. So we can create signs and cues that your clinic is inclusive. And I think in the hospital setting, I know Rashay brought us some little pins here. So it's a safe space, some subtle messages that let people know they feel they are welcome within our system and in our treatment paradigms. So I think that's one thing to do. Restroom policies that are open. And then, so some things you can ask yourself to kind of clarify is, do the images on your health education materials, website, social media accounts, patient engagement tools, and marketing products include LGBTQIA+ symptoms, diverse gender expressions, same-gender couples, all of those things are very subtle signs. And then let people know that it's a welcoming environment and that we do want to care as best we can for this patient population. And then having those materials available that are specific to LGBTQI populations, having referrals available to supportive providers in different contexts, and articles during Pride Month and system literature can be helpful as well. And then also making sure that things as simple as forms reflect this population and their relationships, using partner instead of wife or husband, having more opportunities to have gender neutral terms, also creating partnerships with different community organizations, training staff on how to communicate effectively, and having affirming care as well. And then, as a general rule, is collect some data about sexual orientation and gender. That's more of, I think, a research bent when I was reading this, which is also very important to look at these populations and any specific needs. And then also something that we definitely need to do, and I think in a safe way, is having routine and inclusive sexual histories with open-ended questions and saying things like these are questions asked of all patients, and avoid assumptions about particular patient populations, which I think happens quite often. It's happened with me, so you have to be careful about how you address these things. And then having discussions about sexually transmitted disease, and making sure the patients are comfortable on this topic and is able to have conversations about it and wants to have a conversation about it, because sometimes people don't want to do that. So, but being open about it is really important. So these are all systemic changes, I think, that we can do and we can implement and are more concrete things. And then also making sure people in this community are recruited and retained, and that there isn't that there's some openness about these types of things. So here's what we can offer as a system: prevention and screening, including PrEP for HIV, gender-affirming care, family planning and offering different reproductive options, and also having behavioral health referrals ready and available into safe spaces and to people who are practicing good safe spacing and affirming care in the behavioral health world. So some of it's changing our own. I like this slide because it's like everyone wants change, but if you want to do the personal change, it takes a little bit of work. So this is something that I certainly recognize. It's a little hard for me to sometimes want to change, even as someone who thinks of themselves as relatively open and ready for change. And I find that sometimes when I'm talking with my adolescents, I get a little I get a little nervous, and I feel like I'm making some mistakes, and I probably am with that population. So I think that being open to change and looking deeply and having some introspective during these visits is super important. So, and being humble, even before our adolescent patients who are struggling with some things that maybe we weren't familiar with, and have words and ways of expressing themselves that are a little different and probably okay, right? They're developmentally appropriate to want to express things differently than their parents. So making change is important. So how do we back up? So I really enjoy working with both our psychiatry residents and our medicine and family medicine residents. And this is one of the books that I try to use and try to get even our family med and internal medicine residents to use. And it's Psychodynamic Psychopharmacology. And I think they roll their eyes a little bit at me when I first show them this book and say, hey, can you read this? But I do think it's really helpful. And it's because I think of pharmacology as a general rule, especially for chronic diseases, pretty similar across the board. And there are a lot of treatment resistance that's similar to what we deal with in mental health world. So that's why I kind of say, hey, this is a great introduction to what psychodynamic psychopharmacology is. And this is a good way for thinking about treatment-resistant patients. And how this applies to LGBTQ patients is that they're often not engaging in treatment, and we don't know why, or maybe they left their practice, or something happened in the course of that, and you just don't feel the same sort of engagement with the services they need. And we wonder why, and this happened. This is something, of course, we deal with many different kinds of patient populations. So I think this is a really great book. It's Psychodynamic Psychopharmacology. Check it out. And I put this relatively long quote. I was questioning whether I wanted to do it, but I do think this is a quote from Freud. And I think it's really important. And remembering, again, Freud started out as a neurologist, and why it's important for all specialties to have some training and some understanding of therapeutic models, because I think our patients come to us with therapy needs. So I'm gonna read it and let it sink in. And it's a long quote, but I think it stuck with me from medical school. And then I read it again in this book, and it was good. So we physicians cannot discard psychotherapy, if only because another person intimately concerned in the process of recovery, the patient, has no intention of discarding it. A factor dependent on the physical disposition of the patient contributes without any intention on our part to the effect of every therapeutic process initiated by a physician. Most frequently, it is favorable to recovery, but often it acts as an inhibition. All physicians, therefore, yourselves included, and also any other care providers in here, are continually practicing psychotherapy, even when you have no intention of doing so and are not aware of it. It is a disadvantage, however, to leave the mental factor in your treatment so completely in the patient's hands. Thus, it is impossible to keep a check on it, to administer it in doses, or to intensify it. Is it not then justifiable endeavor on the part of a physician to seek to obtain command of this factor, to use it with purpose, and to direct and to strengthen it? So, and the reason I think this is important, I always remember when we did some of the therapy lectures in medical school, or we were, doing some of the things that are maybe the art of medicine and the softer part of science. there were always the people who would back out and say this is a waste of time. I remember that directly as a quote. But it's so important to patient care. Having a therapeutic alliance and understanding and conceptualizing therapeutic alliances are so important how we provide care, especially in those instances when we're doing chronic care. So yes, depression, anxiety, those things are chronic conditions that we need to treat, and we have to use these therapeutic techniques to talk with people and to understand what they want out of their life and what a better life looks like for them. But it also includes things like diabetes, heart disease, hypertension, and all of those factors that add into treating a patient. And I think this has stood out to me is because whether you walk away from that lecture or not, your patient isn't walking away from their therapeutic need. They still are coming to you and wanting some sort of treatment. And it's our job to help facilitate their needs and to understand what they need. And for LGBTQ patients, there's a lot of different factors, and a lot of it is just normal stuff. It's the chronic disease that we want to treat. It's the, hypertension or the diabetes, but we come into the appointment and we say or we do something and maybe we don't even know. If we have no awareness of how our interaction and what we're doing in that session is going, we might have and probably will have a poor outcome. So I think it's so important to address these general rules and address ourselves in that session and understand that we are, to some degree, doing therapy, whether we're aware of it or not. So I think that was what was really powerful about this for me. So we'll talk a little bit about the book. I don't want to get into too much depth because I do feel like it adds a lot of concepts, and that's not what we're really here to do, but I do think there's some big picture things that we can think about that contribute to the patient experience. So there's a list of different things, non-pharmacological pharmacotherapy variables affecting outcomes of treatment. And what I want to talk about is, I've underlined a few here that I thought were particularly important for LGBTQ populations. So that's remembering early trauma, locus of control, and social disadvantage are really important and something that might be lacking for LGBTQ patients and populations. They feel socially disadvantaged. They feel there might be some early trauma or adverse childhood experiences that contribute to the presentation. And these are things that are all actively happening when the patient presents to your office. There might be different expectations of treatment and feelings about autonomy that also play into this. But these are things that you're coming into and that might affect whether a patient takes a medicine or not, the very simple outcome. There's a lot of these other things that happen in between in the little spaces that we have in that treatment modality. These are things we definitely experience all the way from the emergency room to our clinical outpatient experiences. And these can certainly affect treatment outcomes. It can affect whether a patient wants to leave against medical advice versus stay and engage in treatment. We deal with it pretty directly in things like substance abuse or mental health, but it also is something we'll deal with when we're dealing with any sort of treatment modalities. So being aware of these things, I think, is very important in how we manage and engage our treatment. And then I think one of the things that is also important, and we'll talk a little bit about some concepts you might have heard during whatever training you had, about attitudes of the prescriber that affect outcomes. We call this countertransference. So first part is like transference. So that's what, in psychodynamic models, that's what a patient comes and puts on the other person in front of them. We all look for patterns in our lives. So we all do this. We all think about someone in a different way, like they're like my mom or they're like my friend. And we start to attribute broader intentions on that person. And that causes an emotional response inside of ourselves. And that emotional response is okay. It's something we have, it's going to happen. But how does not only our emotional response, but our general attitudes affect patient outcomes? So sometimes we don't have a solid agreement about targets. So what is the intention of this visit? Also, being authoritarian can affect how we do it. So having a non-authoritarian communication style, I think, can be very important. But that's also recognizing and acknowledging our countertransference, and also, what our own attitudes are about regarding medicine and treatment preferences, and respecting someone else's different sorts of treatment preferences, I think is really pivotal as well, and sometimes hard to do. We let these things get inside of us, and we have different ideas of what a good life looks like, what a good outcome might be, and we might not be listening to our patients and being open and having attitudes that are open about their different outcome and what that might look like. So that can come anything from talking about PrEP and HIV treatment, or of gender-affirming therapy and using hormones. So these things are oftentimes something that we have attitudes about, but that can cause some changes and maybe some poor outcomes for our patients. And then ultimately what we, I think, want to do is have shared decision-making, giving that person some sense of power. There are dynamics of power that we have in each of our relationships and each therapeutic outcome we have. And when you're coming out again and again in a setting, in a medical setting, you can feel disempowered, you can feel nervous and feel like there are going to be attitudes of a prescriber that are going to affect the outcome. And that might be a patient thing, and maybe you're doing the best you can. But understanding that that's there, and then understanding your reaction and your countertransference, your own emotions and your own set of values, and how it might influence those outcomes is important. So talking about holding space. So holding space, and that leads to that discussion of holding space. So holding space means to be with someone without judgment, to donate your ears and heart without wanting anything back, to practice empathy and compassion, to accept someone's truth no matter what they are, to allow and accept, embrace with two hands instead of pointing a finger, to come in neutral, open for them and not you. Holding space means to put your needs and opinions aside and allow someone else to just be herself. So it's common sense, I think, but it's something we need to reorient ourselves to pretty frequently. I think we all learn this in care settings, and I think most people have a natural inclination to want to create this space. But understanding how our own emotions and backgrounds affect this, I think, is important. Reorienting ourselves to the idea of creating safe holding space matters. We're a repository of knowledge that can help with patients' care and be kind and compassionate. But it's about the patient and about their outcomes, and it's about what they see as a good life. So how do we do this? And that's the hard part, and that's the part that requires practice. Like any good art, you get better with practice. So, but we have to be aware of what we're doing, which I think is what Freud was getting at. So I think the first piece of this, my little Plato philosophical bent, is let no one persuade you to cure the head until he has first given you his psyche to be cured by the charm. For this is the great error of our day in the treatment of the human body, that physicians separate the psyche from the body. So, and we'll talk a little bit about this, but I do think it's a natural inclination, especially I think for my medical school colleges, is to really boil everything down to body problems when the psyche matters a lot. So and this is very much within the Greek realm of philosophy, that the psyche is your soul, is how you believe, it's the things that matter, it's meaning, it's all those things that are a little airy and not very concrete. And so I think in some ways we fear that. It's not evidence-based. I think we can say some broad strokes and make some broad statements about the evidence here, but a lot of the things that matter to people, their meaning, doesn't really fall into something we can study or something we can define. So allowing space for that person, that soul, or whatever language you have to describe that piece of ourselves is really important. And we shouldn't separate it from our care. We should allow it to be a part of our care, I think is what Plato is getting at here. And I think some of these principles that we talk about in psychodynamic, psychopharmacology, or any pharmacology that we do. The first one being the one I think about the most, which is avoiding the mind-body split. So this is talking about basically that. Like, sure, yeah, we want to use evidence-based practice. We want to think of the body and the brain as a piece of the puzzle here. We want to think of, we want to learn all the things we learn in medical school or nursing school or even in therapy school, like about the body. Those are matter, right? The brain acts in a certain sort of way. There's chemicals that matter. All of that is important, but there's other things. There's the mind that influences things, and it's a little less sticky. So letting people be and allowing that space. So for there to be both of those things within the patient relationship. I think know who the patient is. I think this gets to that, thing where we have to understand the values and knowing where the patient comes from in regards to how they feel about medicine, how they feel about the interaction that they're coming into, understanding that there's probably some of that apprehension about coming to the physician in the first place, and understanding that a lot of LGBTQ patients have had bad experiences, but then understanding their values and what they want out of life. And I think some of it is also, I think this is a good one, is attending to a patient's ambivalence. So a lot of times patients will come to us unsure about treatment, and probably with good reason. Unsure about tests, unsure about medicines, unsure about therapy and whether it's worthwhile or not. So, but allowing that to be there and not immediately saying, you're wrong, because there's probably some right in that interaction. There is probably some bias, as we saw from the beginning, in the interactions that they've had with other health professionals. Whether that health professional knows or not is different conversation, but there's probably going to be a lot of ambivalence towards treatment. So allowing that space for ambivalence to happen. And then, coming back to one of the other principles is looking for shared goals in that ambivalence. And it might not be exactly what you want the outcome to be in that immediate patient session. And then cultivating, that leads us to cultivate the pharmacotherapeutic alliance. So what are our goals? So by establishing our ambivalence, we can better help to establish goals. Attend to counter-therapeutic uses of medicine, which is probably more unique to, it's unique to pain and psychiatry for sure, for use of, for example, benzodiazepines in a place where it might not be great, might create dependence and addiction. So, and then I think another thing is being aware of our countertransference when we're prescribing. So whatever it is, or not prescribing. So we have to identify and contain it first. I think that's the first goal, is we look at our own emotions and we say, how are these emotions affecting that patient care? And how is that affecting how I'm addressing the patient and using medicines? So we can make good decisions just by being aware of how we're feeling in the moment and how our emotions regarding LGBTQ care can affect how we hand out a medicine. And I think this is a general principle that can apply to a lot of different situations, a lot of different patients, even with different diagnoses. I think cluster B personalities, it talks a little about that. So what does that do when they have a cluster B personality? But LGBTQ patients for sure have this too, where I think we come at a chart, we review the chart, and we come in with our own emotions. So how do we identify that first? That's probably the hardest part. But then how do we use that to make better decisions and safer decisions and more long-lasting and durable decisions with our patients? So I think that's another piece of this. So how does this apply? So I've talked a little bit about it as we've gone along. So we first create a safe space. Our little pens say safe space. So that's, we want to do that for our patients. So we have to think about those things and the modalities and the things we're doing. Like we talked about from the beginning, it starts from the second they will open the website to make an appointment. And it starts from kind of community involvement, DEI initiatives, these kinds of things. And then it continues with staff training and all of those kinds of things. And then using countertransference, so you know how you fit into that person's life and kind of you can attend to their needs in that way. And then knowing, I think a lot of times we often will talk about the right words to use or the right pronouns or the right ways to treat a patient, or one of the Laurelwood things is like, how do we manage roommate situations, those kinds of things. But the first step is always to examine ourselves and our transference and countertransference and where these questions come from and why do we think about pronouns and why do we think about using safe spaces, and that goes to that therapeutic alliance. So then that does mean using words. How do we use the words to affect safe treatment? We'll talk a little bit about how it can go sideways or how it can go really well when we talk about some cases. So, it does come down, even having documentation that isn't inclusive or that doesn't feel right matters. And I've seen it even in radiology reports where it's not inclusive language, and it can affect the relationship, and it can affect clinical outcomes. And then valuing the importance of language, both written and spoken. And aware of our own biases, which I think we all sit with some biases. None of us can be perfect because I grew up in a different age than Generation Alpha, so that certainly affects me. I don't know, I used to be young, but now I'm not anymore. So I do have some biases. I think, what are these kids up to now? But acknowledging that, and then how do you manage that, and being aware that sometimes happens. And so how do I be better in those situations so I can create treatment alliance and we can help people feel better and do better in their lives. So some things that we can do just in a basic way. So we're going to kind of come back so you can be straightforward. I think we sometimes get nervous around the issue, and that's okay, but acknowledge that anxiety, but it's probably best to be straightforward and to try to use the right pronouns. Also using that in forms, I think, can be really helpful. And then don't assume things about patient, whether it's sexual orientation or gender pronouns. And don't talk about biological gender. It's probably better to avoid that. They recommended what is a sex listed on your birth certificate where you assign male and female at birth. It's a little broader language that can be less harmful and less demeaning for a patient, and avoid dead naming a patient. I feel like that has happened a lot because of certain values that occur during the treatment, but it's not helpful when we're talking about chronic disease and helping people feel better in the moment. So these feelings of self-loathing that you're experiencing are, at least in your case, quite understandable. So I put that because I did want to talk first a little bit about my own personal experience when I was a young person trying to get medical care as a gay man, and talking about that and talking about partnership. So one of the hard things that we do is you have to come out again and again. And it's hard. I don't know what that person in front of me, and I talked a little bit about this, is going to feel or is going to experience. And I worry, and do I disclose this time or not? And it oftentimes, instead of being, I don't know, the injury or the chronic disease or the thing I really need experience, the thing I'm thinking about is that, like, how is that going to be interpreted and judged? What rabbit hole are we going to go down because I list that my partner's male? Like, it's not that important. So in a younger life, when going through that, there was an incident where I put that, and then without talking or anything, it was, well, that's a high-risk person, that's a gay male, high risk, let's go ahead and order the whole slew of STD testing, not knowing that they didn't talk with me about it, not knowing that that's something that I've done before. So I open up my labs as a little 20-something-year-old. I'm like, why am I getting HIV testing? So personally, that felt really bad. Like, why didn't we talk about this? Why didn't we have a discussion about my own personal risk? Why did someone make an assumption about my life based on my own experiences? And so I didn't go to the doctor for a long time because I didn't want to. I didn't want to go through that again. I didn't want to experience that sort of what I felt was bias. So understanding that there are consequences, even something you might miss, and understanding that there are consequences when we make assumptions, I think can affect a bunch of different patient populations in ways we don't know. And I don't think the doctor who had ordered those labs meant harm. Now that when I reflect on it, but as someone who's dealing with a lot of emotions and feelings and ways of being around the issue, it created an inner experience that was very uncomfortable to deal with. So, and it led probably to some poor health outcomes now that I'm 40 years old, that I probably should have addressed younger in life. But I avoided going to my primary care doctor because I was afraid of those experiences. So I think it happens whether, you want it to happen or not. I came to that, going back to that Freud quote that I like so much, whether that doctor wanted to have that conversation with me or not, whether that doctor intended on it or not, it happened. I had a feeling and I experienced some avoidance. So really paying attention to how our interactions can influence people, I think is really important. It's shaped in some ways how I am as a physician and the things I feel are really important as a physician, and spending a little extra time and reflecting on my language. I'm not perfect by any stretch of the imagination, but at least thinking on those things I think is really important, because I don't want that patient that's in front of me, whether, I probably am better with LGBTQ patients, but I'm still, like I said, young people are still a little, I don't know, I try hard, but even with patients who might not be of, within the same sort of system of beliefs as me, is how do you take that countertransference and personal bias and reflect on it and help use it so we can have better outcomes, so people can do better in life and experience the benefit and from all of your guys' great education, all the time we spent learning about the body, how can we use that? And that's really what the application of learning about psyche is so important. I'm a big advocate that any person, especially medical professions, have some understanding of the liberal arts and of philosophy and some of these things that I'm really interested in. But I do think it makes us better physicians and more self-aware in those experiences. So that's my experience, but I'd like to invite Rashay up. So I want to invite Rashay. She's great. She works with me in the Behavioral Health Access Center. And we were talking about this, and she's so kind, and I think she creates space. She's an exemplar of someone who can create safe space for people, whatever their experience is. So I thought she was a great person to come and reflect on one of her cases that she experienced. So come on up, and we'll go over the case, and then we'll open it up for any questions you guys might have.
Thank you, Dr. Armstrong. Hey, good afternoon, you all. So I just want to share this case with you all. I work in the emergency room, of course, in the regular hospital part too, but this particular client, I saw him in the emergency room with his family. He came in crisis. So I'm going to tell you a little bit about the case and just the interaction we had, because when we were talking, it did kind of relate to this, just the importance of holding safe space for people. So of course, I've changed some of the names and some of the situations, obviously, to protect this person's privacy. But 13-year-old transgender male, he goes by the name John. His pronouns are he, him, came into the emergency room after a suicide attempt of intentional overdose, brought in by his parents. When John came in, so it's kind of what happened was I got the preliminary information, so I knew there was a suicide attempt. I did know from that preliminary information his age, and that he's a transgender male. And that's pretty much all I knew, and that his parents were with him. So I walked into the room, and the first thing I did was I introduced myself. I said, I'm Rashay with Behavioral Health. I want to talk to you all if you have some time. And I said, before we get started today, if you all can, just tell me what name you would like for me to call you during our time today. And his parents immediately introduced themselves, and then they said, and this is Sally, our daughter. And when they said that, you all, I could physically see as they were saying that, John went from looking at me to his eyes became downcast. He kind of curled his body in, and tears filled his eyes. And so then I told the parents, I said, well, it's good to meet you all. And I looked at him and I said, what name would you like to be called during our time today? And then he said, John. He said, call me John. And I said, thank you, John. And I told the parents, I said, you all, for our time today, because I want to make sure that this space is a supportive space, it's a respectful space, I'm going to refer to you all, each of you all, exactly how you've asked me to. If there are pronouns you want me to refer to you as, I will do that. And that's how we're going to do this space today. And then I told the parents, as I always do, going to talk to John first, and I made sure I referred to John as the name John asked me to. I said, I'm going to talk to John first, so I'm going to walk you all out. And then I'll bring you all back in shortly. And they were fine with that. And as we walked out, the parents they said, look, I want you to know, we really don't know what happened. We know he was kind of, they were still using the pronoun she. We know she was bullied on the bus and maybe some bullying at school. And we feel like she has some friends online. And we think that maybe this has not been a good group of people because we're not sure. This kind of came out of left field. But we love we love her, is what they said. They said, we want to help our child. And I said, okay. And I did let them know, I said, I want you all to know that for me, it's really important. John is here. He's our patient. He's in crisis. It really is important for me to make sure I honor and respect him and always create a safe space. So throughout our time today, I will refer to him as John. And John had asked me to refer to him with he, him pronouns. I'll use his correct pronouns. And in my documentation, I will also uphold that respect. So I want you all to know that because, they might can see it in my chart. So I wanted them to know that. And they were fine with that. So they stepped out. I talked with John. John kind of went on to tell me that, he's been, in the last year and a half is when his gender identity, and then he starts expressing himself to match his gender identity. And so that's when a lot of the bullying has started at school. Recently, he said, even like within a few days, some kids had called him like a thing or it on the school bus, just a lot of isolating. He said they live in a small rural town, and so there's just no tolerance or acceptance for people who are transgender. And he also said that in his home, he said, my parents, there is no tolerance for it. And he said, my mom basically told me, you will never be my son. And that this is not how this is going to happen. And so he basically has said how he got to the point where he felt, I don't know any other way out of this because this is who I am, but everybody else is telling me I can't be this way, and I'm getting bullied at home. I'm getting taunted at, I'm getting bullied at school, no support that he felt like he had at home. And so he really felt like his only way out of the suffering was to end his life, which is what he tried. He told me that when he took the overdose, the online friends, it's a small community of other teens who themselves are LGBTQ+. And he said he had disclosed to them that he had taken the pills and that he was kind of like, I thank them for being so supportive, but letting them know that like, you won't hear from me again. And those friends online actually were like, you got to tell your parents, like, you got a future, man. You can't go out like this. We need you. You have there's meaning and purpose for you. And it may look bad now, but if you can survive this, you're going to graduate one day and get out of your parents' house, and there's a whole world of people who are going to love you and accept you. We need you to be around for that. So those online group of friends are actually the ones who strongly encouraged him to tell his parents. So he said, and he said, because my plan was to take all the pills and just lay down, never wake up again. He had actually wrote a suicide note as well to his parents, just kind of saying, didn't want to hurt you like this, but, we just want to say goodbye. So he ended up, in the encouragement of those online friends, he ended up telling his parents what happened, that he had taken the overdose. And of course, that's when they brought him to the emergency room. When I tell you this kid felt so much despair, so much hopelessness, really didn't think there was any way out of this thing, very high risk for suicide. It was really scary. So I talked with him for a while. I came back, I got the parents, we sat in the quiet room and talked for a while. And one of the things I share with them, and I tried to first of all affirm how much I know they love their child. And you could tell they genuinely love their child. They had a lot of care and concern about their child. And they were probably just trying to figure all this out too. You can tell that this is all they had knew, and this was the only way that they knew that they can't be okay with this, and they have to just stand their ground because that's all they knew. But they desperately wanted their child to live. They didn't want their child to die. And they sincerely seemed shocked that they had gotten to this point. So we talked about that, and we talked about, one of the things we talked about was, right now your child is in crisis. And when people are in crisis and when they're that close to the brink of literally taking their life or having tried to take their life, people need those around them to have wholesome, safe space. Show up, say, I see you, I hear you. I may not understand your story. I may not exactly understand your journey, but I am here with open arms to love and support you and hold you through this. And I told the parents, I said, you don't have to have it figured all out now. I talked to a lot of parents who don't. And there's going to be weeks, months, years down the road that you may do your own counseling and, reflect and all this. But right now, your child is in survival mode, and we're all fighting to keep them alive. And I know you're at the front fighting to keep them alive. And so one of the ways we do that right now is by letting their story and their truth just be and hold space for that. Not condemning them, not shaming them, seeing them. This kid needs someone to just see them. We talked a little bit about, in general, just, how high risk their particular child was with all of the different factors that were going on. And I also shared with them, I said, here's the thing. This situation is not homeless. One of the things we know, LGBTQ plus youth, they are 6 to 7 times more likely to attempt suicide than their peers. But one accepting adult in their life, just one, can literally decrease their rate of suicide by 40%. Y'all, that is huge. One person. Definitely as healthcare providers, that also, we sometimes are that one person during that interaction, even though it may be a brief interaction and we're only seeing them, maybe like in the emergency room where we're not going to see them that much, or maybe at Laurelwood where we may see them longer, or outpatient where you may have, really be able to kind of follow their care. But for these parents, I told them, I said, for right now, can you all be that one person in their life? Because I don't know if he can survive this without you all. And they were like, no. And they were in tears. They were like, we love our son. Like, we didn't know he was struggling this much. We thought this online, and I did let them know too. And I said, the friends that you were concerned about that he was talking about online, because they really thought those friends were the reason this person may have been suiciding. I said, I don't know who those friends are, but we need to thank our lucky stars from them, because from what he said, they are the ones who strongly encouraged him when he did not want to do it, to immediately wake you all up, tell you all that he had taken that overdose. And they were encouraging him, man, you have to stay around. You have purpose. And I told them, I said, so what I'm telling you is that your kid, that was your kid's lifeline. But those are also people he don't know. He doesn't know. They're not people in his daily life. They are online friends who don't live locally. He also is going to need some support from folks who are in the trenches with him. And so we kind of had that conversation. And of course, like I said, I affirmed the fact that I could only imagine. I can't even imagine how much they love their kid, because I know they do. Any parent does. Well, most parents. I would say most parents love their kids. So anyway, you all, we went back in the room, and I didn't tell them, you have to call John, you have to use he, him pronouns. I never told them that they had to do that. These are the parents. I guess they can do whatever they want to do. I just exemplified and told them, from when I'm with them, so that they wouldn't be caught off guard or find my referring to John as John disrespectful to them, since they had referred to John as, she and use the other name. So when we got in there, and you could almost see as we were walking in there, especially with the mom, I could just see her heart just softening. You could just see it in their countenance. And when we got in the room, we're talking about next steps and what'll happen next. And I'm, saying I'm going to talk with the provider. We're going to look at, different ways we may support you. At this point, John was still very actively wanting to die, was actually very disappointed that he wasn't dead, and was still wanting to die. So we talked about, the different options, and we was probably going to talk to the provider, but looking like we might end up doing inpatient at Laurelwood for a couple of days, talk about what that looks like. John was also very desperate for help, and I think there was a part of him that was relieved to know that maybe there was some help out there, and maybe he really didn't have to die to get relief. But I will say one of the things, and I almost started crying and I didn't, but it was so beautiful, you all. At some point during the conversation in there, John's parents started to refer to him as John. And they started to use the he pronoun. There were a couple of times they slipped up and said she, and then they just self-corrected. And I want to say it probably was the next day when we found John placement at an inpatient facility, but I don't know, how they are doing now, but I know for a while you could just see when they actually referred to John as John, y'all, there was just something different about him. There was just this glimmer of hope that was a little different. So I think when I think about creating safe spaces, I think as providers, it can start with us. It can start with us being bold enough, whether it's a kid or adult, to just say, I will show you unconditional positive regard and respect and dignity in this moment, and I'm going to model that. And be okay. And even in my documentation, I made sure, that I did say, John prefers, pronouns, blah, blah. He prefers to go by the name John. And I use that throughout my documentation. I personally feel like that's important, because as other providers are picking up this person's chart and caring for them and reading, I think it helps us all kind of get in the language of using something that most honors and respects that person, so that they feel most seen and supported. So do y'all have questions? I'm sorry if I'm talking too fast, but that's kind of the nuts and bolts of that case study.
Thank you, Dr. Armstrong. Thank you, Rashay. I will remind you, if you have a question and you're viewing online, please enter it in the chat section and we will ask for you. I did have one comment from online. Thank you for your great example of providing safe spaces.
Thank you guys for presenting. I had a question. I know you pointed out on one of your earlier slides that change really needs to come internally from an institution, but I saw Dr. Baumiller in the room as well, so I didn't know if you, Dr. Baumiller, or Dr. Armstrong, or Ms. Rashay, if you guys know of any institution that grades systems on inclusivity. Is there anything like that exists out there to help kind of promote that?
Yeah, the Human Rights HRC, I forget the last name, but they do grade on equity. We actually haven't been scored at NGHS, so I think we have some good comments and everything. I mean, you guys can correct me if I'm wrong. I was looking it up recently, but yeah, they grade institutions based on policies, inclusivity, restroom stuff, all the kinds of things we were talking about on the systems-based care. So different organizations will get a score. So go to hrc.org and they'll probably give you Human Rights Campaign. I got it. Came to me. But yeah, you can look it up there and kind of see where different places lie. Maybe I don't know how you get scored, but that might be something we consider. But that would be, if you're curious, go there.
Thank you.